Hello, everyone, and a warm welcome to this seminar on global health and threats to global health. My name is Victoria Veres, and I'm an associate with the Swedish Institute of International Affairs. We're hosting the seminar with support from SIDA and Forum Syd. We're very happy to see all of you here today, and we're very happy to have a distinguished panel here to discuss those topics with us. Welcome, Amy Lockwood from University of California, Helle Ågård from REACT, and Pia Engstrand from SIDA. Welcome, we're looking forward to hearing from you. So we're here today to discuss the current developments in global health and the threats, the new threats, and the not so new threats, and those threats that we seem to have a hard time battling. How serious are they? What can be done? What is being done? And who should be doing something about them? I'm very happy to hand over those questions to today's panel. So we'll hear 3 short presentations, and then we will have a discussion, and there will be room for questions. So we're opening up and really want to hear from you too, to hear your questions. And if you want to continue discussing this on Twitter, there's the hashtag UI event and Stockholm Act. So please feel free to use them. So I'm handing over to Amy Lockwood, who is Chief of Staff at University of California at San Francisco, the Global Health Sciences. Amy Lockwood has a long and varied experience in development issues. She's an advisor to Born Free Africa, and she's had previously had leading roles in at the Center for Innovation in Global Health at Stanford and at the Clinton Foundation in India, and done many things in this field, and it will be really interesting to hear from you. So please.
Thank you so much, Victoria. Thanks for the kind introduction and for inviting me here today. I'm honored, humbled, and a little bit nervous to present to you. In particular, to give you fair warning, some of the things I'm going to talk about today, not everyone will agree with. But my goal isn't to have everyone agree. Global health is a really complicated subject, and I hope that we can find ourselves in a conversation that will take us further to figuring out what we do to solve all of the problems in front of us. So I began my career in global health with one big question. I wanted to know, why do so many people suffer and die from diseases that we know how to treat and cure? I asked this question years ago as an outsider. I was an MBA student. I'd gotten my degree in business, and I'd spent a long time being a market researcher. And I moved into the field of global health with a little bit of bravado and a lot of naivete. Now, after more than 10 years of working in the field in 40 countries for foundations, for NGOs, for academic institutions, and with social entrepreneurs, I still don't have an answer. The question still haunts me. To be sure, lots of progress has been made in global health. In the last 25 years, lifespan has increased from 57 to 71. The average rate of under 5 mortality is halved. About 7 million lives have been saved from malaria. We've eradicated smallpox, guinea worm, and we're on the way to eradicating polio. Millions of lives have been saved. And yet, despite the medical advances, like the drugs, diagnostics, and vaccines, diseases like HIV, TB, malaria, and even just the act of giving birth continue to claim too many lives, a disproportional amount of which are in the developing world. For example, while there's still no cure to HIV, we do know how to radically disrupt transmission, particularly from mother to child. We have a way for, if women take antiretroviral medication, that you can reduce the effective transmission rate to only 5%. But we don't do that in every place. While in the US and Sweden, less than 100 children per year in our large countries are affected through transmission this way, in a country like Kenya, just last year, 6,600. And a couple of years before, it was 13,000. So we have the tools to solve these problems, and in some places in the world, we apply them, but not everywhere. The WHO recently estimated that there are over 400 million people that don't even have access to primary health care. just the basic things that you need to relieve everyday suffering. Many of those people are also in low-income countries. And yes, there is limited infrastructure. There are fewer healthcare providers, and there are constraints on overall resources for health. But in response, the global health community provides more than $35 billion per year to address these inequities. Unfortunately, as we saw with the Ebola outbreak in 2014, even this isn't enough. Ebola is another disease that we know how to prevent the transmission of. And it wasn't for the lack of knowledge that it spread through Sierra Leone, Liberia, and Guinea. It was for lack of a strong health system and lack of coordinated management for the response. To prevent the next tragedy like the Ebola outbreak, or the everyday tragedies of women dying in childbirth, or people dying from drug-resistant tuberculosis, we need to do more. And we aren't going to have the resources to do it. We're not going to have any more money. Given the current political and economic environment, development aid is likely to go down, not to grow. Furthermore, we can't rely only on medical innovations to help us through. Certainly, more of this would be helpful, but we really need to start focusing on applying the knowledge we already have to the people that need it. And this leads me to bringing back my earlier career. What I think we need to focus on is perhaps the least sexy thing. It's management. Now, to be clear, this is not a revolutionary thought. In fact, it's actually a really old idea, one that's been periodically recycled year after year. In global health, we call it health system strengthening, and it's been around since the 1970s. But I think we keep coming back to it because it's fundamental. Without a strong system that's well managed, people will continue to needlessly suffer and die from diseases that we know how to treat and cure. Now, this would be the time that I should come up with a silver bullet to tell you what the answer is and that we can just all get out of this room and do it. Unfortunately, I don't have that. But it's the focus of my research now to try to understand what we can do better. And what I can tell you are a couple of things that I've learned about why we don't know the answer to this question. First, health system strengthening or management is challenging. And I don't mean to sound like Donald Trump and just be complaining about a problem that's hard, but it is hard. Systems involve multiple interrelated elements. Things like finance and supply chain, human resources, information technology, regulatory and legal issues. In addition to those things being dependent on one another, they're also very time-sensitive and context-specific. There's not a silver bullet here. The first job that I had in global health was working for President Clinton's foundation, and I was leading the pediatric HIV program there. One of the most important things we did at the foundation was building out models for how many antiretroviral medications were needed across the world in order to negotiate volume discounts. And we were able to do this by building strong models that were rooted in epidemiological understanding of the disease. But it wasn't just the epi. We needed to understand the system underneath it. We needed to know where the people were that were able to test and treat children. We needed to know what the supply chain looked like so we could see how the product would move throughout the country. And we needed to understand the financial systems to make sure that the producers of these drugs were getting paid on time and would continue to deliver them. If we hadn't had people that were focused on the management, our forecasts would have been wildly inaccurate. We wouldn't have been able to reduce prices from $600 to $60 per patient per year, and we wouldn't have been able to increase the number of children treated from 15,000 in 2005 to over 800,000 today. Second, although the field of global health is full of extremely skilled professionals, clinicians, basic scientists, epidemiologists, and the like, there aren't a lot of individuals that are professional managers. That's not to say that healthcare professionals can't be good managers. They can. But it's not what you're trained to do. As a doctor or a nurse or a physio, you're trained to care for people. And the last thing most healthcare professionals want to do is the paperwork that helps move the system behind them. There's also a belief that by putting into place management principles that somehow in public health we're giving ourselves over to the private sector, and that has something to do with a profit motive. And while that suspicion isn't entirely unfounded, resisting the look at operational efficiency really prevents us from putting in place tools that have allowed large organizations to do a lot of things really well in the world. Now, I've been really lucky that I've worked with organizations that have seen this and have understood the benefit of hiring both managers and clinical experts. I'm very proud to be on the faculty of the University of Global Health Equity in Rwanda, a unique school that in 2015 launched a master's program to help prepare clinicians with management and leadership expertise. And we've just had our first group of students graduate this last summer, and we're really excited to see what they'll be able to do mixing both the technical and the functional expertise that they've now been able to build. Finally, it's really hard to alter the structure of an industry when those who are in power don't have a lot of reason to change. In the case of global health, those with power are oftentimes the donors, the philanthropists, that have the money behind what's happening. And right now, the philanthropic world is really focusing in on vertical programs, looking at each specific disease and not crossing over. Again, when I worked at the Clinton Foundation, we were focused on pediatric HIV. But one year, there was a really bad dengue fever outbreak in Cambodia. And the country manager and I broke all the rules. We knew that even though our money had been earmarked for pediatric HIV and we were really just supposed to be buying the antiretrovirals, if we did that and we waited, those kids would have died. So instead, we funneled some money off to the side and we bought the commodities that the hospitals needed to treat dengue. Now, we were afraid that we were going to get in quite a bit of trouble. Fortunately, the donor was very enthusiastic that we had actually done the right thing. But the structure of the system didn't support that. And we had to do something that we feared we might get fired for in order to do the right thing. Now, I'm not saying that it doesn't make sense to have a vertical focus all the time and that it's for some silly reason that that's how organizations have been set up. But perhaps the time to have done that has passed, and we really need to be focusing on looking at the overall systems. I'm working to solve all of these challenges that I've just talked about, which keeps me pretty busy. And the one I wanted to just talk about a little bit today is the one that's bringing together philanthropy and global health. And that's thinking about exactly what can donors do differently. And I will push again to say that we really do need to be focusing on overall health systems so that we bring together the knowledge we have from our disparate vertical areas. But I'd also make the plea that donors and philanthropists really start thinking about the role of management, and specifically to focus on providing the funds to allow managers to do the work they need to do. Perhaps even suggesting that the organizations that are getting the funding have management involved, that there aren't line items that say you can only have 10% put to overhead. Overhead is how we organize everything. It's not a bad word. There's a critical role for philanthropists to play here. And in guiding the design and implementation of programs, we can do a lot more together. We do have the knowledge to cure the ills that we have in the world. It's now our responsibility to put them to practice. Thank you.
Thank you. So that's nice to hear some pro-overhead talk. That's not so common. Thank you so much. That was very interesting. I just wanted to follow up and ask you if you could give a good example, maybe of a country that works like this towards its donors with the strengthening of the systems, or with a donor that's walking in this direction that you're mentioning.
Yeah, the country that I would put forward is Rwanda. Rwanda has done a remarkable job at thinking across its entire health system. Now, in part, that is because Rwanda has been in an interesting position of power because of the way that we ignored them during the late 90s. They were really able to push back on donors and say, look, rather than each of you doing your own separate programs, this is our plan, and we expect you to fit into it. So it's a unique situation. but it's one now that does provide a very strong model for a government to say, this is our overall health plan, and you as donors need to fit into this plan so that we can ensure that we're able to manage across all of the different streams of funding and programs.
Mm-hmm. Interesting. I hope we'll come back to that a little bit later in the discussion. Thank you so much. And I will now hand over to Helle Aagaard, who is a policy advisor at REACT, Action on Antibiotic Resistance, and who has also previously been working for Médecins Sans Frontières. And we will hear a little more about a specific problem within this issue. So please, Helle.
Thank you so much. First of all, Steve, thank you for the introduction, and also thank you for the invitation to come and speak here today and provide some perspectives on antibiotic resistance into this discussion. I think what you've just presented sort of it's a perfect segue actually for me to make a couple of points. Given that antibiotic resistance is not a disease, it doesn't have the civil society organizations that are, strong and behind diseases like HIV or TB. Antibiotic resistance is really horizontal, and that poses a lot of challenges in terms of how the world is able to respond to it. So I work for REACT, Action on Antibiotic Resistance, which is an international network. It's based on 5 continents, and we're working to raise awareness among policymakers about antibiotic resistance and its drivers. We also promote best practices, and we try to help shape solutions on how to manage antibiotic resistance in a more sustainable manner, and in a way that can really work in resource-poor settings, which is what we find in many developing countries. The name of the conference today is New Threats in Global Health and the Role of Philanthropy. And I would actually start by noting that antibiotic resistance is really nothing new. It's not a new threat. In fact, Alexander Fleming, the Scottish scientist that discovered penicillin in 1928, already back then warned us that use and misuse of antibiotics would lead to resistance, and it did and has. This is because the development of resistance in bacteria is really a naturally occurring phenomenon. It's a result of natural mutations that happen when bacteria split and multiply, to put it quite in a basic way. And resistance development in bacteria has always occurred, and it will continue to happen. It's really their mechanism of adjusting to the environment in which they are. Now, resistant bacteria is all around us, and it's also inside us, in our gut. And it kind of lives there in a bit of a checks and balance with all the good bacteria that we also have in us, that we really rely on. And having them inside our gut doesn't make us sick. Now, the problem arises when let's say the way I am right now, with the resistant bacteria I may have in my gut, take an antibiotic course tomorrow. What happens then is that the antibiotics, let's say, wipe out the good bacteria that are susceptible to that antibiotic, and you end up in a situation where the few bacteria that has developed a resistance mechanism to the antibiotic that I've just taken, they are able to thrive, and they have an advantage in surviving, and that's a phenomenon that we call selection. So let me see here. So put in a simple way, it's really the combination of natural mutation on one side that happens all the time in bacteria, and then there's the selection pressure that antibiotics poses on bacteria. And this is what drives antibiotic resistance. On top of that, the spread of bacteria is, we live in a globalized world today, and people travel, and we trade across borders, and bacteria follow that, right? So the spread is also emphasized by and sort of fastened by the fact that we're global and we live in a global world. I'm saying this because it's important to keep this in mind, that it's something that is naturally occurring, and because we mutations will continue to happen, and the use of antibiotics will also continue to happen. We need to be able to treat sick people and sick animals. And you even have a situation in countries today where in particular in developing countries, where there are a lot more people dying from lack of access to effective antibiotics than from resistance. And they, in time, will also need they urgently need to get access to effective antibiotics. So it's not like we're looking at a scenario where we just phase out the use of antibiotics and then the problem will be solved. That's not really on the table. So it's really about managing the development and spread of antibiotic resistance and finding a way to doing it in a sustainable and actually also a just way, where developing countries in particular, their perspectives are taken into control or into consideration. So why has antibiotic resistance then become this topic that a lot of people are talking about, that is sort of on the rise in public awareness and also in political awareness? Well, the short answer is that we're getting to a point where we're on the brink of really losing this very precious resource that we have and losing its miracle, the world's miracle drugs. Because the particular thing with antibiotics is that the more you use them, the less effective they become, right? Because you have antibiotic resistance developing. So in the last 80 years since penicillin was discovered, we've been massively overusing antibiotics, both in human and in animal health. And add to that no new drugs or no new class of antibiotics has been developed since 1987. That's a long time ago. And we're looking at a situation right now in the R&D field where new antibiotics are at least 10 years away. So we're basically running out of options to choose from in our medicine cabinet when we are treating infections. The consequences of this are really quite dramatic. Not only are we about to lose some very precious and very effective drugs that can cure some of the most common infections, but antibiotics are also really the cornerstones of modern medicine, right? So care for preterm babies, cancer cures, transplantation, organ transplantation, hip replacements, these kind of things, they're almost impossible to do without effective antibiotics. So if we take away that cornerstone, we're looking at consequences that are far more dramatic than just not being able to treat the resistant infections. And today in Europe, 25,000 people are estimated to die every year due to resistant infections. Similar numbers in the US. In South Asia, a child dies every 5th minute from resistant blood infections today. And these are really conservative estimates. The truth is that the global monitoring surveillance systems that we have in place is quite patchy, and it's really only starting, with a lot of support from Sweden actually, to improve. So I'm saying all this just to say that it's not a new threat, it's not a future problem, it's something that is here right now and that we're seeing the consequences of quite clearly. On the economic side, the World Bank is estimating that in 2050, the damage caused by antimicrobial resistance will be on par with what we've seen in 2008 with the financial crisis. And as with what we've seen with climate change and what we know about climate change, the consequences are about to hit the developing countries much harder than they will in high-income countries. Low-income countries could lose up to 5% of their GDP due to antibiotic resistance. And this could in turn push 28 million people back into poverty. Right? So all the boxes that you're seeing around us here, which are all symbols of the 17 global sustainable development goals, a good handful of those are going to be impossible to achieve if we're not able to tackle and manage antibiotic resistance in the coming years. So the costs of inaction are really quite immense, in particular for the poorest countries. So we urgently need to find ways of reducing the unnecessary use, both in humans and animals, and also with the discharge that we have of antibiotics into the environment when we produce them. Luckily, I'll end on a good note, the world has kind of woken up. In 2015, the WHO, the World Health Organization, adopted a global action plan that is both strong and comprehensive. It covers human health, it covers animals, and it covers the environment. And as of May this year, about 2/3 of all countries around the world have taken that national action plan and tried to develop have taken the global action plan and tried to develop national action plans that outline how they're going to tackle antibiotic resistance in their own countries. So the challenges that we stand in front of right now are not so much about driving the issue up the agenda and getting policymakers to take it serious. It's really a question of moving from plans to implementation. And in that, there's obviously a question on funding. Money is needed to ensure the plans do not stay on paper but are implemented. And that money will need to have a much broader way of being used, and it needs to take much more of a system approach if we're to be effective on this, because it's everything from immunization to surveillance to rational use in hospitals to education of people to understand that you don't need to take an antibiotic when you have a cold, you only need to take it when you have a bacterial infection. Keeping antibiotic resistance on the political agenda. We've seen before, 10 years ago, there was an upsurge, we need to really tackle antibiotic resistance, and then it kind of disappeared a little bit again. We can't really afford to let that happen, so there's a big need to keep it on the political agenda. Philanthropists have a role in that, NGOs have a role in that, and policymakers also have a role in that, and the general public has a role in that as well. And then finally, we need to sort of kickstart the development of new antibiotics, and for this there is really a need to move away from what in the past has been, and also present, is a kind of an over-reliance on the pharmaceutical industry to solve it. They have consistently, over the past 2 decades, withdrawn themselves from the anti-infective area. And there's really a need to kind of look at how we can kickstart this area with or without them, but that we need to sort of consider alternative options. So, as REACT, we push for these ideas very hard, and we first and foremost think that these are governments' responsibilities. This is something that governments need to act on. Of course, philanthropies have a huge role to play as well. I think their actions need to be transparent, and I think to some extent they need to be a lot more accountable for their work than they are today. But overall, I think the field of antibiotic resistance would benefit hugely from having the big philanthropies coming in behind it and making sure that we both have the political push for tackling antibiotic resistance, but also, of course, the economic muscle that they come with. So I'll end my talk on that note and look forward to PS.
Thank you so much. This is very interesting to hear, and also very troubling. That's how I always feel when there is a talk about antibiotic resistance, because I get the feeling that we're already too late. The new ones are 10 years away, and nothing's really happening. Is that feeling correct? Are we already too late?
Well, it's hard to tell if we're too late. I mean, there are certainly diseases already that are completely resistant to, completely resistant to all the existing antibiotics out there. And we're also seeing resistance mechanisms in bacteria, primarily on the animal side, that are resistant to our last line antibiotics. So the situation is pretty dire. It's hard to say when it's too late, right? But there's certainly room for, or an urgent need to act now. And the challenge will be definitely to move it from the policy level and the international level and into countries, and see action happening on the ground.
Yeah. We'll come back to that too, and also about the financing when we discuss together later. Thank you so much, Helle. And we will move on to another threat that is also not new, but a threat that we've been seeing for a long time and having trouble battling. And it's maternal mortality and this area of threats and questions. And we will move on to Pia Engstrand, who is lead policy specialist on health and SRHR at the Swedish International Development Agency, SIDA. Please. Go ahead.
Thank you very much, and thank you for the invitation, and to my co-panelists. I can't resist but commenting that we have an all-female panel here, as you note. And I was telling Victoria coming in here that I was just twittering, replying to Dr. Tedros, who is the Director General of WHO, because he had posted on Twitter proudly a picture with the leadership of WHO and the World Bank working on health together, talking about a new era that they are going into, and the picture was with 25 men. And I said, this can't be the future. You have to change the leadership. And they replied saying, yes, we are aware about this. So I don't feel ashamed. We can be an all-female panel here today. So, as you said, my name is Pia Engstrand, and I'm lead policy specialist for health at SIDA. And SRHR, that means sexual and reproductive health and rights, which is a large priority within our health development cooperation. We have 3 overall priorities for Swedish development cooperation: sexual and reproductive health and rights, SRHR, health system strengthening, and reducing child and maternal mortality. And commenting on what you said and the importance of what you said, Amy, we are proud funders of national health systems. We always have that as the preferred mode of support, supporting a country's own national health sectors and the budgets. But I will talk today about maternal health. During the MDGs, we saw substantial progress on people's health. We live longer than ever, and a child born today is expected to live until the age of 71, and that's remarkable. And we've seen progress, as Emmy said, in a number of important areas, not least in tackling communicable diseases such as AIDS, tuberculosis, and malaria. At the same time, this progress is uneven. And it is the poorest countries and countries that are struck by conflict and fragile states that are lagging behind and have not seen the same progress. At top of this, they're also facing the new health challenges, as Helle has been talking about. Antimicrobial resistance is one, and the other one, the big one coming, is of course non-communicable diseases that now creates a double burden of disease for poor countries. And they are at the same time tackling the old diseases, so to say, and the old health challenges, including child and maternal mortality. Every year, more than 300,000 women die in complications related to pregnancy and delivery. That is 800 women every day. And 99% of them are in poor countries. Perhaps needless to say, maternal mortality is caused by poverty, but maternal death also causes poverty. Mothers die and often leave a whole family behind, and in that family then many times children have to leave school to take care and cater for siblings and household chores. This leaves them very vulnerable, and especially the girls are then facing a lot of vulnerabilities, increasing the risk for child marriages as one example. Reducing maternal death was one of the MDGs, and that was extremely important because that made the world and poor countries focus on this particular issue. It was very important. The target was to reach a reduction of global maternal mortality with 75%. Unfortunately, the world didn't reach that. It was the MDG that was furthest behind reaching its goal. It was only reduced by 44%. So there is a lot more to do, and that countries can do, and that we as funders should do to reduce maternal mortality. And maternal mortality is, of course, also very uneven. There are large disparities between countries, within countries, and between women with high income and low income, rural, urban. The risk of maternal death is highest among adolescent girls. Complications in pregnancy and childbirth is leading cause of death among adolescent girls in developing countries. Maternal mortality is preventable, so why are women and girls still dying? The short but sad answer is that decision makers and societies have not prioritized and prioritized women and girls' lives high enough. We know what we should do, as we have heard. The tools are there, but we're not using them and we're not funding them. So I will point to 6 major factors that affect women's that affect and cause maternal mortality. First of all, women and girls are not able to decide over their own body and their sexuality. They are not able to say no to sex. It's simple as that. We are far from gender equal in the world. And here this needs a holistic approach. It's about gender equality, and it's a long-term issue to work on. A second one that is very closely to the first one is, of course, the fact that women are not able to access contraceptives. 214 million women in the world are still lacking access to modern contraceptives. It's also a question of these women perhaps having access to pills, but pills are not perhaps the preferred mode of contraceptives. They need a wider range of contraceptives, exactly like we do in our countries. The third one is long distances to healthcare settings for antenatal care and for delivery. This also shows that solving the problems around maternal death is a multi-sectorial issue. We need health systems that are in place, and it's a holistic approach that is needed. The fourth one is cost related to pregnancy and delivery. In many poor countries, healthcare is still paid out of pocket, and if it is just a small amount, that small amount may be too much to pay. The fifth one is the low quality of healthcare. We have increased access to healthcare in the world. And the same with education. Many more children go to school today, but both within the health sector and the education sector, it's a question of quality, not only increasing quantity, but also increases in quality. And the sixth one is unsafe abortions. And unsafe abortions amount to 8 to 18% of maternal mortality. And as you know, in many countries in the world, abortions are surrounded with highly restricted legislation. That needs to be changed, and we need to be able to provide safe abortions for those who need it, to be able to effectively reduce maternal mortality. So those 6 areas, they are there, and we have tools. Coming to funding, that's another thing. We need to be able to increase the funding with the right mechanism and the right tools. Today, unfortunately, we have a new government in place in the US, as you know, that is the largest donor when it comes to contraceptives and reproductive health. This government and Mr. Trump took a decision very early on in his administration time to stop funding organizations that in any way work on safe abortion. That means now that major organizations that work on contraceptives and safe abortion are now losing the US funding. And this is something that will have huge implications, unfortunately, on maternal mortality. But we are many countries and donors who are proud to try to fill the holes. It will not be easy, but Sweden, including many other European governments and others, are stepping up and raising our voices and funding to be able to compensate for this. Thank you.
Thank you. This was very interesting, and I just wanted to pick up on the last thing that you mentioned there. Do you see after this change, are you optimistic or pessimistic? I mean, do you see a trend moving towards following the Trump line, or do you see that there is a reaction against this, that there will rather be a positive movement, that other countries, like you say, step forward, or organizations step forward? What is your view on the reaction that you've seen around the world?
Yeah, I think it's both, actually. I think the world working and committed to women's rights and women's health are very concerned. At the same time, as you're saying, there are also positive signs of many actors stepping forward and really trying to defend the issues now. But it remains to be seen. I mean, the global gag rule, Mexico City policy, as it is called, will only have an effect after a couple of years. So it's only then that we can say what the results are.
Yeah, yeah. Thank you so much. And I would like to thank you all three for your presentations. And I will open up for questions from you. And I have some questions too. So if you want to start thinking about it and raising your hands, and we will walk around with microphones. And while you think of your questions, I will also start by summing up a little bit on a topic that all the three of you have touched on in different ways. And it's to what extent is money the bottleneck? I'm thinking because Amy, you talked about management as a bottleneck, and Helle, you mentioned political will as very important, and Pia, you said it's not a priority. So to what extent is it actually a lack of money? You can choose who wants to start. Amy, would you like to start? And we will move on, because I'd like to hear all three of you.
Sure. I don't think it's money. I think we're spending $36.4 billion per year in development aid. And that's on top of the funding that countries put in for their own health.
Oops. Yep.
Sorry, so again, I don't think it's funding. I think that we have quite a bit in development aid. We're starting to see more and more countries, their GDPs grow and putting in money for their own health systems. I think it's the efficient expenditure of that funding. So again, I come from a business background, and I would say that we can always do more. We just have to use our money more wisely, and there are certainly several ways that we could do that by thinking about moving across the different verticals. I will say, and this is one part that I shouldn't have cut from my speech, Sweden has led the way. Sweden has led the way in health system strengthening, in thinking about how governments take the lead, and has consistently been at the forefront of very controversial issues. So I think, to both apologize for my government, but also feel some optimism that by looking to countries like Sweden, we will continue to see the direction that we need to go, and hopefully in 3+ years we'll be ready to follow you again.
Helle, I think you can. I think yours is working.
Is it working? Yeah.
Yeah.
It's working. Is it the funding? I mean, for an area that doesn't have funding, it is about the funding. maybe on a macro level, the total amount of money that is available, maybe that is not the question, but then it becomes more about how is that money then prioritized, and what areas does it go into? Does it go into vertical programs? Does it go into health system strengthening? How, and for a topic like antibiotic resistance, which is something that covers so broadly and is really a horizontal issue, how do we ensure that the funding is there, not to earmark it to antibiotic resistance, but to make sure that every little component that we need to strengthen in a health system and in health education, etc., gets the funding that it needs, so that action can take place in countries. And I think from our narrow perspective, if you can call antibiotic resistance narrow, right now it really, quite in the very short term, is about funding, because if there is no funding to support the poorest countries in this world in implementing their national action plans and doing a priority of, like, is it best for us to invest our money in immunization and make sure that all our kids are protected against pneumonia? Or is it better for us to do interventions on wash, facilities for like hygiene and clean water, right? I mean, those are some of the topics that governments will be battling with, and how do you make that call, really, with a limited budget? It's difficult, but you can't get around the fact that money is needed.
Yeah.
Thank you. I think I agree with both of you, of course, but really picking up on Amy's point that it's a question of how you spend and allocate that money. Coming back to the fact that the world in the beginning of the 2000-ish said that the most effective way to do development cooperation is really to provide, as you said, support to countries' own plans, to support health sector plan and education sector plan, and to have the countries themselves, governments and civil society, not only governments, but really the country's own plans and their priorities at the heart, and to fund that. That's really, and that was called aid effectiveness. In 2000, in the lead up to the adoption of the Sustainable Development Goals, a high-level meeting was held in Nairobi called Financing for Development, and there these actors agreed that no, it's not aid effectiveness, now we're talking about development effectiveness, because we have new kids on the block like philanthropists, and it's really a question of many more actors today. It's not only donors, traditional donors. So we agreed to the term development effectiveness. The sad thing is that while in the beginning of the 2000s, many donors agreed to fund countries in this way, we have now moved backwards. We see a sad development where we're going back to sector or narrow project vertical initiatives, like you spoke about, Amy. It's a very sad development, and Sweden is today very lonely, talking about the need for core support to organizations and countries. So yes, I hope we can walk the talk together with others.
Thank you. We have some questions from the audience. I know we have 2 questions, so we'll do the 2 questions first, and then we'll get a chance to answer both questions. And if there are more, please raise. There is a 3rd question just here on the, and even a 4th. So I think we'll pick up on all the questions, and then we can split the questions between us. And I would like, it's so nice to get as many questions as possible in from you, so I would ask you to keep them short, and as well as the answers, so we can try to answer everything. Thank you. Yes, please.
Yeah, I listened with great interest to the 3 interventions, which were all important and interesting, but the title of the seminar is New Threats to Global Health and the Role of Philanthropy. I haven't heard anything about philanthropy, so I was hoping that perhaps in the remaining time something can be said about that, because it's an important issue, as is the first part, but it requires some attention, I think. Thank you.
Thank you. I'm glad you picked up on it, because otherwise I would have. So thank you so much for that question. Yeah. Please.
Hello, my name is Karen. I'm from Karolinska Institutet. the medical school here in Stockholm. And thank you so much. It was really interesting to listen to the three of you and your presentations. I was wondering about how you see the rapid urbanization happening across the world in each of your fields. Is that seen as an opportunity or as a challenge? And how do you then work with that huge change in health system strengthening, in antibiotic resistance, in reducing maternal mortality? Is that seen as a factor? Do you work with it? If so, how? What are the results so far? Thank you.
Thanks.
Could you repeat what type of organizations you said?
Urbanization.
Urbanization.
Yeah. So the fact that people are moving into the
Yep.
cities from the rural, from the countryside.
Yes. Thank you.
Thank you very much, Åse Smedler. I would like to stress one of the things that you have taken up, which is institution building system, healthcare systems and others, which is in fact also building democracies. Through the process that Pia described about aid effectiveness and how you measure interventions, now we talk about development effectiveness, it is lost the fact that building strong and healthy or accountable institution takes many years. And I would like to hear from you, what initiatives do you see to put it back onto the agenda, because it is long-term interventions that is needed. And in that same issue, the new development aid agenda has a very important horizontal question, which is gender equality. How do you see it being tackled in the area we have been looking at now, and perhaps including with philanthropy?
Mm-hmm. Thank you. And we have a last question on the front row.
Göran Thomson, Swedish Institute Global Health Transformation Site. Thank you for all contributions. Three things. First, I'm happy, Amy, that you mentioned that Sweden has been in the lead. And that's actually true, not only for health system strengthening, but also in the antibiotic resistance containment movement. And tribute to SIDA, there is too little of that. Because SIDA has been supporting both the Alliance for Health Policy and Systems Research and REACT. Secondly, words are important. I agree with the first person who made the intervention. I'm puzzled by your heading, the title of this, New Threats to Global Health and the Role of Philanthropy. And especially new threats to global health. You haven't talked about new threats to global health. Just want to clarify that. And it's old. So the thing is, the issue is not diagnosis, but intervention, prescription for action. And I also think words are important. Don't talk about developing countries. It's misleading. It's old. In Agenda 2030, we have joint problems. Talk about resource-poor countries, low-income countries, because poverty is a basis of so much. And don't use misleading words. My question is, given that Rwanda is such a fantastic example, and that the health minister at least used to be a female, and that the parliament, I think, has quite a lot of females, how important is it to nurture female leaders in institution building, for philanthropy, etc., etc.? So that is my question. Thank you.
Thank you so much. So we have some different questions, and just to repeat really fast, and then I will ask you to pick up on the questions. You don't all have to answer all the questions, but you can actually pick up on the ones that you feel are for you or that you really want to put something into. So it's on philanthropy, and I'm really glad that that came up, so we get a chance to each comment on the importance of it and the role of it on your topics. And then urbanization. How important is it? What role does it play in this? Building democracy and building institutions. Is it on the agenda? New threats versus old threats, or are they just old threats coming up to the surface now? Is that the case, or are they new, or are we just late, like we talked about, realizing old threats and pointing them out as new. And also, how important are the female leaders? So I'll ask you to start first, Amy. You can pick up on which one of the questions you like.
Does this work?
No.
No.
Sorry.
Okay. So I'm double mic'd. So I'll talk a little bit about philanthropy. So I live in San Francisco, and San Francisco is sort of the epicenter of the new philanthropy, thinking about impact investing and using the models of business to make sure that the funding that's being put into things like development are having an impact. I will say that I actually think that this is one place where it's a problem to use the terms of business. Words matter in this space in particular. It's both a problem because it doesn't work the same to put $1 in investment into a social issue as it does to put $1 into a company and expect a return on investment. That's not to say that the general concept doesn't make sense. But when we get to the nuts and bolts, I think that's why we're seeing the resurgence of focusing again on specific verticals, because it's much easier to measure the impact of $1 when I'm looking at how many drugs did I buy, how many children came through my center, how many buildings did I build. And it's part of the old guard's responsibility to the new philanthropists to educate them around why these ideas are not going to get us further down the path. That we, again, my overwhelming message here will be, we have to look at the overall system. And the only people that are responsible for the overall health system in a country is the government in most cases. Now, I could get into a long conversation about the role of the private sector, but I will leave that aside for right now. Private sector in terms of delivering healthcare. So let's just keep it simple and think about the private sector. So the things that I've said about what I would like to see donors do, I can get into some very specific things, going grant line item by grant line item about what I'd like to see donors and philanthropists do. What I will say about the overarching story is that we've got an opportunity with new philanthropy to educate them about the mistakes we've made with old donations. And there are things that we should pick up that are new and interesting and wonderful, and there are things that we should not fool ourselves into thinking are new and interesting and wonderful. I hope that answers a little bit of the question on philanthropy. It's challenging, and it's wonderful to have new people be interested in the area. We do need more funding if we can get it. But one example I'll just give is the Gates Foundation, which we can argue has been an amazing addition to global health. And yet the Gates Foundation is not a sovereign nation, and yet they still sit on the board of the WHO, the Global Fund, with sovereign nations. It's run by a handful of individuals who do a lot of really amazing work. And yet they also, when they started, focused just on health technologies and not on thinking about the overall systems. When an organization can think about how do I spend money coming up with a new toilet or a new condom, when we have toilets and condoms that work and they don't focus on the things that we don't know how to do, there are some real questions about what new philanthropists have to say. Again, I'm not afraid of controversy, so please bring it on if you don't agree with those things.
Thank you. Helle, would you like to continue and pick up on the...
Yeah, I mean, so talking about philanthropy, I think I'll probably sort of draw on the experience I had before joining REACT, where I was working for a big humanitarian organization, Médecins Sans Frontières. And I was working a lot on access to medicines and raising those issues at a political level in Brussels, working towards the European Union. And in particular there, I mean, in the policy field, that's different from like implementation work, but in the policy field, you definitely see that philanthropy donors come in and they are probably not able as themselves to do what we know as sort of advocacy, right? But you see them then finding organizations that are doing advocacy for them. And we would have huge disagreements, for instance, with an organization like Gates. And they are very focused on interventions, on health technology interventions, not so focused on how do you make sure that they are affordable in the countries where they're supposed to be used. And we were having a big discussion on those things. But But the thing is, it kind of becomes a little bit behind the scenes. It's not who are you having the discussion with. I mean, there is questions on accountability, on like when they decide that they have a certain position on things, who are they accountable to? And they have such a massive muscle financially, and also in terms of the contacts that they have, and at the political level, that there are questions on who are they accountable to, and who has the power to basically question the choices and also the policy positions that they take. That's a real challenge.
And it's a very interesting discussion. Pia, would you like to follow up on philanthropy as well? Or you can pick up on one of the other questions.
Just a short comment on that. I think I fully agree. The foundations are extremely important in many ways. We can learn a lot from them. They provide important resources, and they have a skills management that we can learn from as donors as well. The fact that Bill and Melinda Gates Foundation is the largest donor to WHO, one can talk about that. It's even bigger. They are bigger than the US. Bill and Melinda Gates Foundation funds 18% of WHO's entire budget. And they are not accountable to their citizens, of course. Global citizens in one way. From my perspective, I also can comment on the fact that many of them are foundations, the big foundations are US-based. And that includes a US perspective on things, which may include good management, a lot of good things. On the other, it also has a tendency, for example, in the area where we work on sexual and reproductive health and rights, it means including a value perspective, for example, on not funding abortions. So there are limitations to this type of funding too. If I pick up on another questions on institutions and the importance of having strong institutions as the building block, as part of I couldn't agree more. And from SIDA's end and from the Swedish end, we have seen funding to institutional strengthening going down, which is a problem that we are very much aware of. And it's the priority of the government really to get us focused more on that. So just to echo what you said, is women and female leaders important? I think they are, and I think most of us in this room agree that it's not for a reason that we are talking about why female leaders are important. Some apply quotas. I think it's important to have a diversity when it comes to representation and resources everywhere, including in health settings and global health. Yeah.
Thank you. Helle and Amy, would you like to pick up too on, we haven't talked about the urbanization. Yeah. So if you would like to pick up on that, because I guess that's quite an important issue in your field as well.
Yeah, so I can't claim to be at all an expert on urbanization at all, but obviously there are some points that come to mind. In particular, number 6 there, you see the water and sanitation issue that has a huge importance for antibiotic resistance and how it's spread. Of course, if you have very dense urban areas with people living in perhaps not the best conditions, that's the optimal fertile ground for development of resistance, but also the spread of it. So of course there are very clear overlaps between and considerations that needs to happen within the sort of general trend of urbanization and the impact that it has on antibiotic resistance, definitely.
Mm-hmm. Mm-hmm. Thank you. Amy, would you like to have a finishing note, because we're running out of time a little bit?
Absolutely. I'll talk about the importance of female leaders. So just look around the room. It's mostly women. And this is the case in healthcare. This is the case particularly in global health, except when you look at the 25 men that are leading the World Bank and the WHO. And this is something that I think will continue to be a struggle, but I want to suggest to the young women in the audience that there is so much space for you here, but you have to take the space. And it's a difficult thing to do. It's difficult to stand up and give a talk on something that feels a little bit out over your skis and be reminded totally correctly that some of the time you've used the wrong language. It's a tough space to be in, and it's a tough space to say things that people disagree with. But there's no one right answer here. And I think women can be really good at communicating with one another about our ideas in a very open kind of way. And then sometimes when we get up in front of audiences, we shut down a bit more. I'm thrilled to be on an all-female panel. I think I might say that I only want to be on all-female panels for a while, because no one does that, and it's time. It's time for us to take the space that's there. And thank you to the men that are in the audience that are giving us space. And please continue to make room, because if we don't take it, no one's going to give it to us. There are issues with Rwanda. I will not say that that is the right model to follow. I just want to make sure that I note that. But it's something that I didn't realize was going to be an issue in my career until very recently. And I now wish that someone had told me that the things that I was finding hard as a woman were real things, and to keep fighting about it anyway.
Thank you so much. I just want to say thank you to the panel for your interesting presentations and your answers, and for talking about this with us. And thank you all for your questions and for coming. And I hope to see you all again soon, somewhere. And I just wanted to say that our idea here is to really, because this is a huge topic and it's very difficult, and we have an hour, and what we wanted to do is to lift the discussion and start thinking about these. And there are so many questions that needs to be asked and needs to be answered, but we don't have all the answers. So I hope that this discussion will continue, and I hope you leave here with some ideas. And if you haven't taken one of those, please do, because here you've got the chance to follow up on some of the topics that we've been discussing and read more about it, and keep in touch with us and keep discussing it. Thank you so much. Thank you.